And with cranioplastic surgery, today's patient story, hole in the head. So if you've seen in this patient story series, plastic surgeons really increase the capabilities of our surgical specialist colleagues. You can see this in our assistance with dermatologists, in the stories, the big reveal and the lip flip. In hernia from hell, I work with general surgeons to address a very complex hernia. In no way BRCA, I work with surgical oncologists, for example. And this is an interesting case in which I'm working with neurosurgeons to increase their capabilities by really addressing all of the soft tissue issues so that they can focus on what they need to do for a patient. This patient is a 66-year-old who had a devastating car accident in March of 2023 involving prolonged hospitalization, multiple injuries, including among them was a right subdural hematoma that the neurosurgeons removed a portion of the parietal bone to decompress the brain and treat his hematoma. And about 5 months later, in August 2023, they replaced that bone flap, secured it with plates and screws for a cranioplasty, but unfortunately, the patient developed a wound dehiscence as shown here. So these are pictures when he was sent to my clinic. Unfortunately, he was sent about 8 months out, and so wound care was attempted to try to heal this, but unfortunately, this is not a durable solution. So you can appreciate his prior incision as shown here. You can appreciate some tenuous skin in the region of his prior incision, and you can see the bolt, the EVD scar that's present there. Now, of course, the reason he was sent to me was for this wound dehiscence, where there's an exposed piece of hardware and screws that are present. So if we look carefully at that, we zoom in on that, this may look like a fairly innocuous situation. So you've got some wounds, exposed hardware, but there's no erythema or active drainage or pus that's evident, but this is a very tenuous situation. This is certainly infected. The hardware is certainly infected, deep to that certainly infected, and represents a significant risk for meningitis, encephalitis, certainly failed healing of his bone flap, which was the case. So this is not a durable situation, and wound care was attempted for this, and I applaud those efforts, but it's just not going to solve the problem. So in conjunction with his neurosurgeon, we took him to the operating room 9 months out after that autologous cranioplasty. As I mentioned, it was a delay in referral there. And our goal with this procedure was to assess what's the extent of infection, remove that infected hardware, and see what the status of the soft tissue was. For orientation, you can see his right ear there. Unfortunately, when we opened up, we encountered purulence and infection both on top of the bone flap and deep to it on the dura itself. And so this required us to remove that bone flap as shown here and actually discard it, which is unfortunate, but that's what we had to do. And ultimately, cultures from this OR grew out Propionibacterium acnes and MSSA, methicillin-sensitive Staph aureus, which was treated. Now here he is at the end of that procedure. You can appreciate the exposed dura as shown there, which is just the brain itself, surface. And then you've got healthy residual bone. I've tried to outline roughly the size of the bone defect that's there. And then just close the skin and remove some non-viable tenuous skin. So here he is at 6 weeks off. We wanted to give him a full 6 weeks of IV antibiotics to treat this. And as you can appreciate here, having the absence of a rigid bony cortical support of the brain impairs function enormously. So you can see the right side, that significant concavity. Look at his left upper extremity function as shown here in the clinic.
I just want to get a video document everything. So you're saying the left side is a lot weaker?
Yes. Before you can raise it up. Like
yes,
this.
okay. Okay, very good.
So you can see how much weaker he is on that left side as his wife is describing there. So at 8 weeks, we took him back for cranioplasty and soft tissue coverage. Now, cranioplasty, of course, we can't use his own bone because that's already been discarded. So in this case, in conjunction with my neurosurgery colleague, we decided to use a PEEK, polyether ketone synthetic implant that's 3D printed and customized, and then we would cover this with a flap, which I would perform. You may look at this and think, well, do you really need a flap? I mean, it looks like he's got good skin there. Well, of course, there's no skin deficit here because of the concavity, but on restoring the native calvarial structure, we're certainly going to need soft tissue, so I wanted to plan accordingly. And I did as such, as shown here. So workhorse flap in this setting, there's a lot of options. One I love is the ALT flap, which is a skin flap from the thigh, as shown here. So here's his right knee on the table. That's the thigh. That's going to be the site from which this flap is isolated. Now here he is in surgery. The cranioplasty has been performed. You can appreciate that bone defect is now covered with the cranioplasty is shown there. I go down to the thigh, and here's just an intraoperative video showing the flap harvest from the thigh.
Strap evaluation, we've isolated the ALT flap we've separated out the vastus lateralis branch. It's on a single perforator. There's a secondary perforator that's attached by fascial connections. Let's place it here, demonstrating the pre-flap anatomy.
And you can appreciate that pedicle, that vascular pedicle going on the deep side with a single perforator. And here's just other images from surgery. The flap is then disconnected. The vascular pedicle is shown there, transferred up, and microsurgical anastomosis is performed to the superficial temporal artery and vein, as shown here prior to inset. Now here's the flap when it's fully covered, inset protecting that cranioplasty, protecting that hardware, and represents a nice closure for him. These are just other views of that showing the contour and inset of the flap. Now, if you look carefully at that image I showed you of the patient here, there's that probe, and in case you're not aware, that's called a bioptics probe, and I use this on virtually all of my free flaps that have a skin component, but I mention it here because it was actually critical in the complication that occurred with this patient and potentially saved this patient's life, actually. So what this is, this probe that's connected on the flap goes into this machine, which gives you a real-time continuous reading of the tissue oxygenation status of your flap. I have an app on my phone. This is a screenshot from my phone that shows this app where I can, from home, monitor these flaps and see how things are going. And this is a very sensitive technology for doing that. It's been well established. So from day 0 to 2 after his surgery, his cranioplasty and free flap, his bioptics reading, that percent, rock solid, 65. I don't think it budged more than plus or minus 1 or 2% in either direction. And I check this pretty obsessively. However, on day 3, I vividly remember a Saturday evening, I'm checking this, and I see that it's dropped to 57. And it's kind of a slow, gradual, and the kinetics matter here. It's a whole nother discussion. And then it drops to 55. And I say, I'm just gonna go check on him in the neuro ICU. By the time I get there, it's down to about 50. These are pictures I took of his consoles at various points. So I went to the bedside to examine him, and the flap looked great. It still had good circulation, but he was acting very different. His mental status had changed, and his left upper extremity was weak. He had actually regained his strength after doing the cranioplasty, but it was now weakened. And so I ordered a SAT CT scan, and this is what it showed, unfortunately. This is an epidural hematoma. It is a life-threatening situation in which blood is collecting and basically creating mass effect and pressing the right cerebral hemisphere down, and there's only so much pressure that it can tolerate. So you can see the cranioplasty there, you can see the flap, and you can see that large hematoma. So I immediately called my neurosurgical colleagues in. They were fantastic, came right in. We took him to OR emergently, evacuated the hematoma. Here we are after we've lifted the flap up, we've washed out the blood, and not only did this save the patient's flap, this saved the patient's life potentially. Reinset the flap. Here he is on day 5, examining his left upper extremity function again.
Can you raise your hand up for me, your left hand? Excellent, okay. And then can you open up your hand for me? Open up, yep, peace. Okay, good, open like this. And make a fist. Great, okay, good control of your arm. Up one more time for me, and then back down. Up real big, great job. Day 5 from free flap.
And so here he is on day 7. It's me and my neurosurgical colleague and the patient right before discharge home. So how did he do? Well, here he is at 2 weeks post-op. You can see the flap is healing in very nicely. And here's his function of his left upper extremity.
2 weeks out from free flap from the right thigh here, which is healing up nicely, incision there, to the right scalp. And I noticed immediately after his cranioplasty, he could raise that left hand. Then he had the epidural hematoma, and he lost that. Let's see what you got. Can you lift your left arm up? Well, your left side. There you go. Yeah, excellent. And back down, and up as high as you can. Excellent. Okay, good job, Donald.
And hand function evaluation.
Can you make a fist? And open up your hand. And then make a fist. And then back up. Great job. Good.
And here he is, my most recent follow-up here at 6 weeks with a big smile on his face, healthy flap, good contour restoration following his cranioplasty. So I hope you enjoyed this patient story of a hole in the head. As always, make sure your surgeon's board certified. Ask for pre-op and post-op pictures. We'll see you for the next patient story.